Recently, some large trials were performed on neoadjuvant or perioperative therapy for non-small cell lung cancer, especially locally advanced disease. So in fact, the question is, after neoadjuvant therapy, after neoadjuvant chemoimmuno especially, should we restage the patients regarding the mediastinum? In the large trials, this has not been done. Only CT scan was done, and when there's no progressive disease, the patients went on to surgery. However, I want to indicate that in earlier trials, for example, the EORTC 08941 and the Intergroup 0139 trial of induction chemo or chemoradiation, so no immunotherapy because not what used at that time, restaging was found to be important because those patients who started with N2 disease and who still had persisting N2 disease after the induction therapy had a very poor prognosis. So and that prognosis was really poor, and there were some studies from Essen showing that those patients with persistent N2 disease had a 5-year survival rate of approximately 5%, so very low. So I think even after, personally, induction chemoimmuno, it's important to restage the mediastinum by invasive ways. Now we have EBUS or mediastinoscopy if you have done before an EBUS. But as it was not done in the large trials, the audience thought it was not necessary. But I think if we know more data about the N2 disease and persisting N2 disease after neoadjuvant therapy, it could be very important to restage the mediastinum, as I don't think that surgical resection will improve the prognosis of those patients. So what we currently do outside the trial is we try to prove N2 disease by EBUS, so endobronchial ultrasound. Then we give the induction therapy, neoadjuvant therapy, and then we restage the mediastinum. And if we found clearly N2 disease that remains in the mediastinum, then I think the proper treatment is radiotherapy and not surgical resection.